Hello, everybody. Welcome back to Emergency Medicine Quest. Continuing our respiratory medicine series, today we will talk about asthma in this lecture. Jumping straight into the anatomy and physiology. So, asthma is a very complex immunologically mediated condition that is characterized by periods of variable and recurrent symptoms, airflow obstruction, and bronchial hyperresponsiveness. Asthma is a complex interaction of the immune system, the environment, and the genetics. If we compare a patient with asthma with a normal person, people with asthma show bronchial hyperreactivity in response to various environmental and infectious stimuli. So, it could be allergic, like environmental dust, viruses, occupational, or even non allergic stimuli like exercise, aspirin, and menstrual cycle. Pathophysiology wise, in these patients, when they are exposed to an allergen, their airway gets infiltrated by neutrophils, eosinophils, and mast cells. Mast cells and eosinophils contain and they release certain mediators and cytokines like histamine, prostaglandin, leukotrienes, TNF, and this causes prolonged bronchial muscle spasm, edema, and mucus production. Airway remodeling is basically the persistent structural changes in the airways that is caused by repetitive or chronic airway inflammation. So, chronic asthma patients, after a point of time, if we do a biopsy of their airways, as we can see in this image, we will see that a lot of new vessels they form, the epithelial barrier gets altered, there is mucus plug in the airway, goblet cells undergo hyperplasia, and there is subepithelial fibrosis. As for the signs and symptoms of asthma, so most of these patients will present with cough, dyspnea, and wheezing. We can divide it into slow onset asthma and sudden onset. So, slow onset has a female predominance while sudden onset has a male predominance. In slow onset, the symptoms usually occur over at least 6 hours to days, but in sudden onset, the symptoms develop rapidly in less than 6 hours. This is normally triggered by any respiratory tract infections, but the sudden onset is triggered by allergens, exercise, and stress. When we are taking history from patients coming with asthma, we should ask about the possible triggers, the onset of symptoms, the severity of symptoms, particularly if they've had previous asthma exacerbations. Any and every comorbidity must be identified, like diabetes, peptic ulcer, hypertension, psychosis, because their medications can precipitate asthma. All current asthma medications should be reviewed, including the number of times and the amount they use. Furthermore, they must be asked for any hospitalization or ED visit for asthma in the past year, if they have stopped using oral corticosteroids, or if they are adherent to their asthma medications, or did they have any near fatal asthma with intubation or mechanical ventilation. Generally, we will notice that patients who are having mild or moderate asthma exacerbation, they will come and be able to speak in sentences or phrases, slightly elevated pulse or could be normal with increased respiratory rate, and they will have normal oxygen saturation. But those coming with severe acute asthma, they'll only be able to speak in 1 to 2 sentences at a time. They might be agitated, restless, hunched forward, tachypneic, tachycardic, and hypoxic. Remember that wheezing does not determine the presence, severity, or duration of asthma. In terms of risk factors for asthma exacerbation, it is more common in females, and normally the specific risk factors for exacerbations include a history of one or more exacerbation in the past year, poor adherence to their medications, uncontrolled symptoms, incorrect inhaler use, or smoking. A specific context in which asthma presentation or management can become different and challenging. So number one is cough variant. Many a times patients with asthma only present with their symptom that of cough. They can also complain of cough being present only at night, in which case many other differentials also should come to mind like GERD, chronic sinusitis, postnasal drip, and laryngeal obstruction. Cigarette smokers represent a challenging population with asthma because they can also have COPD, and generally they come with lots of acute asthma exacerbations. Exercise-induced bronchoconstriction is also one of the variant of asthma. It is theorized that airway dehydration because of increased ventilation and increased osmolarity of the airway causes it. Any athlete with exercise-induced asthma must take prophylaxis like face mask or nasal breathing to allow warming and humidification. Pre-exercise warm-up, avoiding allergens, and use of a short-acting beta agonist 5 to 10 minutes prior to their exercise also goes a long way. Perimenstrual asthma affects 40% of asthmatic women, and their pathophysiology is not very well understood. Be mindful that asthma can appear at any age, including the ninth or 10th decade of life. Generally, when elder patients with asthma present, they have a higher morbidity and mortality. Overweight patients, those that have BMI more than 25, generally have poorer asthma control, higher admission rates, and greater risk of complications. Aspirin exacerbated respiratory disease. This is a tetrad of nasal polyps, chronic sinusitis, and asthma. A fourth component that has been described is sensitivity to COX-1 inhibitor drugs like aspirin. Aspirin exacerbated respiratory disease is a common precipitant of life-threatening asthma, and 25% of these people will require mechanical ventilation. So these patients must avoid aspirin and must avoid NSAIDs, and the mainstay of their management is with inhaled corticosteroids. As for diagnostic testing in the ED, one of the cornerstones of management is peak expiratory flow. Routine measurement of peak expiratory flow should be a part of ED assessment and monitoring. Any peak expiratory flow less than 50% should alert the physician for an acute severe asthma, and less than 33% is for fatal or near fatal asthma. An eye should be kept on pulse oximetry, and the AM saturation is between 94 to 98%. Anything less than 90% suggests a more aggressive approach. Blood gas is another tool that is commonly used in the ED. Initially, when a patient presents with asthma, they have hyperventilation that washes out their CO2, and this leads to respiratory alkalosis. These patients begin to hypoventilate, and with hypoventilation, the PCO2 first normalizes and then it increases, causing hypercapnia and respiratory acidosis. ABG should not be routinely done in acute asthma cases. It should only be considered if A, the saturation is less than 92%, or B, if the peak flow meter is less than 50%. A VBG also can be considered as a screening tool for hypercapnia, considering it's less painful for the patient. Some of the other blood testing that is done in asthma, so leukocytosis is often done, and people interpret it as a sign of ongoing infection, concomitant ongoing infection, but it does not necessarily indicate a superimposed pulmonary infection. In fact, use of corticosteroids can transiently increase the WBC counts. Serum electrolytes are usually not altered in these patients, but albuterol can cause transient hypokalemia, hypomagnesemia, hypophosphatemia, but this is not of clinical significance. Remember that symptoms of asthma can overlap that of heart failure. So if you have a patient who is known to have heart failure, remember to run by a BNP. Hyperlactatemia is also high in asthma, and it is thought to be secondary to the albuterol or increased work of breathing. But overall, routine testing of blood is not recommended in asthma exacerbation. It's of little value in acute asthma unless we're thinking about underlying infection like pneumonia or pneumothorax. And the ECG should be done in all patients presenting with acute dyspnea. In severe asthma, the ECG can show a right ventricular strain pattern that will reverse with improvement in airflow. Before we talk about the definitive management of asthma, we need to first know what are the objective findings in severe asthma. So, if the pulse is more than 120 beats per minute, if the respiratory rate is more than 30, if there is use of accessory muscles, if you do an ABG and it shows PaO2 less than 60 or PaCO2 more than 45, and most certainly our peak flow meter less than 50%, they're all indicators of a severe disease. As for the treatment, any patient coming in with acute dyspnea to ED, we treat with our A, Bs, and Cs. So if their oxygen saturation is less than 94%, then we should definitely start them on supplemental oxygen. Let's discuss what are the classes of drug available to manage acute asthma. So first we have inhaled short-acting beta agonists or SABA. So drugs like albuterol fall under this category. If the patient is coming with mild to moderate asthma, then this albuterol can be given as a metered dose inhaler. But if the patient is coming with severe or near fatal asthma, then we have to give it in form of nebulization. As for the dosing, metered dose inhaler, so we give 6 to 12 puffs every 20 minutes. And as for nebulized solution, we are going to give 2.5 milligram of albuterol again every 20 minutes. The other category is long-acting beta-2 agonists. So drugs like salmeterol come under this category. Salmeterol has an onset of action of about 20 minutes, and that is why it cannot be used in acute asthma. We have another long-acting beta agonist called formoterol, and this has an onset of action within minutes, similar to albuterol, so it can be given. But remember, regular use of long-acting beta agonists without concomitant use of inhaled corticosteroids leads to greater hospitalization and greater asthma-related death. So do not give long-acting beta agonists without inhaled corticosteroids. As we just discussed, steroids are an important part of acute and chronic asthma management. They reduce mortality, they reduce relapses, subsequent hospitalization. So once again, we can divide it into systemic corticosteroid and inhaled. Early systemic corticosteroids are important for patients who fail to achieve lasting improvement with our initial use of short-acting beta agonists. Remember that oral corticosteroid is equivalent to IV, and usually we are going to prefer giving the patient oral if they can tolerate it. Otherwise, if the patient is very ill, unable to swallow, is actively vomiting, then we can give IV. The recommended initial dose of oral corticosteroids is 50 milligram prednisone. If IV methylprednisolone is used, then the dose becomes 125 milligrams per day. Normally, we divide this in 1 or 2 doses until we can switch back to oral or the peak flow meter reaches to 70%. Use of high-dose inhaled corticosteroids within 1 hour of arrival for acute asthma without systemic steroids reduces the need for hospitalization. Now, if we decide to give a patient systemic corticosteroids, the patient feels better and then we are going to discharge the patient. We should not stop the steroid cold turkey. So we can give an outpatient regimen. So an accepted regimen is 40 or 50 milligrams of prednisone about 5 for 5 to 7 days. The third category of medication is anticholinergic medication, which works as a bronchodilator on the smooth muscles. So one of the drugs that we commonly use from this category is ipratropium bromide. This is the preferred anticholinergic agent for acute asthma exacerbation, and the maximum effect with inhaled ipratropium is about 30 to 120 minutes after administration, and it can even last up to 6 hours. So the recommendation in line at the moment suggests that we should add 0.5 milligram of ipratropium with the first 3 albuterol treatment in severe acute asthma. But if we're going to give it as a metered dose inhaler, then we can give about 8 puffs every 20 minutes for 3 doses. The next drug in line is magnesium that relaxes the bronchial smooth muscle and dilates the asthmatic airways. Normally, we give magnesium if the patient is coming in with severe asthma. The optimal dosing for magnesium is 2 milligrams IV over 20 minutes. There can be some side effects to magnesium infusion, and this is dose related. So it includes warmth, flushing, sweating, nausea and vomiting, muscle weakness. As we are moving on, we are now going to get to medications that are rarely used in asthma management. So the next one is methylxanthines. And one of the drugs that comes under this is theophylline, which was previously used majorly to treat asthma but is no longer used because it has a very narrow therapeutic range, and particularly in an exacerbation there is no efficacy. We also have leukotriene modifiers. So drugs like montelukast, zafirlukast, they usually come under this category, but there is no role in asthma management that is acute. Basically, Heliox is a combination of 60 to 80% of helium with 20 to 40% of oxygen. And the way that it works is it reduces the resistance associated with gas flow through airways, reduces respiratory muscle work, increases the diffusion of carbon dioxide, and improves alveolar ventilation. However, it has not been shown to demonstrate to decrease the need for intubation in severe or resistant asthma. Non-invasive ventilation can benefit selected patients with severe and resistant asthma, but remember that it is not a substitute for endotracheal intubation and mechanical ventilation. So those patients that have alert mental status, intact airway reflexes, and ICU admission will be warranted for them. They should be given a trial of non-invasive ventilation. And finally, mechanical ventilation. So it is required in about 2% of all asthma exacerbations. And normally the indication for mechanical ventilation is coma, altered consciousness, cardiac or respiratory failure, refractory hypoxemia, and failure of non-invasive ventilation. When we are ventilating patients with asthma, there are a couple of things we need to bear in mind. So one, if we use a large endotracheal tube, then it is going to facilitate airway suctioning, remove the mucus plug, and even help in bronchoscopy if needed later on. A drug that is particularly talked about a lot is ketamine, which is usually in dose of 1 to 2 milligram per kg. This is the preferred drug for induction because it has bronchodilatory and sympathetic stimulatory properties. Propofol is also there that has some level of bronchodilation properties, but it is not used because of its hypotension. You can couple up ketamine with either succinylcholine, which is in the dose of 1.5 milligram per kg, or you can use rocuronium in the dose of 1 milligram per kg for intubation. Remember, when we have intubated these patients and are managing their ventilator settings, permissive hypercapnia is alright. Our goal should be to maintain low tidal volume, that is 6 to 8 ml per kg for each person, and also to maintain our oxygenation by keeping a check on the FiO2. And this brings us to the end of lecture on asthma.